Thank you very much, Irene. It's a pleasure to be here. This is entirely different because I'm a gynecological cancer specialist, so I operate on people and I cause the menopause in younger people and then send them off to you to try and figure out the best way to take care of their symptoms. As you can hear, I live in England, it's my home, but I'm Irish, so I have to say a happy St. Patrick's Day to you all. I'm going to bring you through my area of things. It is quite different, and all of these cancers we talk about in gynecology are actually rare cancers. But there are issues that are occurring which are probably relevant to your practice as well, as we see things changing over the incidence of these diseases. If we look here, we can see both endometrial cancer and ovarian cancer are essentially postmenopausal diseases, but nevertheless, there are a significant number of cases which will occur in the premenopausal woman. So if you take endometrial cancer, about 25% will be premenopausal when we operate on those women. Some of them can be quite young as well if they've got a hereditary aspect to their disease. And the same occurs with ovarian cancer, or this disease we call ovarian cancer, though, as I'll show you later, is probably a bit more complex than it seems. What is evident, though, are the trends in endometrial cancer are increasing. So it's practically doubled in the last 15 years or thereabouts, which becomes a big, big problem. The trends in ovarian cancer have remained essentially static, but we need to be careful that some people will say there's a fall off in ovarian cancer, but that might be due to a registration change by calling it fallopian tube cancer, and therefore your figures look as if there's a fall, but in fact they're probably remaining pretty static. So if we take endometrial carcinoma, what is causing the increase in the condition? And if we understand that, then we can institute preventative measures so that it will not occur. We can reduce its incidence. And this is one of the things, of course, that is contributing quite significantly, not just to the gynecological cancers, but cancers in general. And most countries are probably feeling the squeeze of the health service trying to accommodate the fact that life expectancy has jumped. So if you look historically, we do get these life expectancy jumps that occur. But of course, in a 30-year period where your life expectancy has gone from sort of 76 into nearly 84, that's quite a significant jump, and it has population impacts as well, because that's the age group where all the illnesses are going to occur. So there's a case we're living longer, but some of us living longer, but maybe not with the quality of life. So with both of these cancers, endometrial and ovarian, being in the postmenopausal range, one anticipates that there would be some form of increase. Another thing that's happened in the field of gynecology, not in gyne-oncology, which is different, is the fact that hysterectomy rates have reduced. So in the UK, for example, from probably 1990 to 2000, there was a 50% reduction in hysterectomy rates due to the fact that medical interventions, which were more cost-effective and less dangerous as well compared to surgery, were introduced. And therefore we've got a significant fall in the amount of wombs being taken out. And in view of that, you're leaving an organ whereby you inevitably will have an increase of endometrial carcinomas. A third factor, of course, is the issues surrounding breast cancer, which has a direct relationship, of course, with both endometrial and ovarian cancer. And for many patients nowadays with breast cancer, fortunately, most are going to be cured from the disease, meaning, again, we've got a large population of women who maybe 30 years ago would have died from the disease, never developed their endometrial carcinoma. Because they're living, we're going to get an increase both in endometrial and ovarian carcinoma. So there's a good side to that story, but inevitably an associated downside. And with regards to all these variables which are increasing the risk, and there's many, many more in epidemiological terms, there's not an awful lot we can do about it. If people are living longer and breast cancer survivalship is going up, these are all excellent things that are occurring. Hysterectomy rates going down. So they're variables we've no control over for either of these cancers. But there is one thing, and there's no doubt about this, is the association of obesity and endometrial carcinoma. And you yourselves will have in-depth knowledge of all the endocrinological and hormonal changes that occur in the body with association with women who have got obesity issues. And again, pretty much like in the United States, we can see that there is, I think we can use the word, an epidemic of obesity in the UK. It's just increasing to such an extent, it's quite incredible. From a practical viewpoint as a surgeon, 10 years ago, we used to have to sign off for a theatre table that was rented for big people. And you had to sign the form to say if it breaks, it's your fault. And some of these women, we couldn't actually weigh them. And you sign this thing, operate on this line, and then they take the table away. That table now is the standard table. And there's a bigger table again. So the one, 15 years ago, which we bring in, when you're building a new theatre, you just put that one in. And that gives you an idea that it's well worthwhile doing that because of the incidence of obesity. And this is directly correlated as well with, of course, the predicted endometrial cancer incidence. And we are fitting this trend. I mean, it is going this way, there's absolutely no doubt about it. As I say, in the UK, we've had the doubling already of it, which is quite an unusual thing to see in a cancer world. It's not something that you want to see. A lot of them are curable, but it is very, very concerning. And it's all due to the fact that we overeat, eat the wrong things, and don't do a little bit of exercise. Quite interesting. Another group that we have, which are extremely rare, are the hereditary ovarian cancer, or endometrial carcinomas. And it's quite possible, depending on your relationship with gynae cancer, if you've got a gynae cancer specialist, you should work together, because these are the type of patients where you do have problems with regards to the need for HRT. I'll explain this as we go along. So HNPCC, or Lynch type syndrome, Lynch type 2 syndrome as it's called, these are usually given a history in their family of colonic carcinoma between males and females. And then the females, of course, are at increased risk of both endometrial and ovarian cancer. Remember, endometrial carcinoma, the survival patterns aren't too bad. Ovarian cancer, I'm afraid, for many people, is lethal. And therefore, what do you do with these patients to prevent these diseases occurring? It's really difficult to know. There's progestogenic approach that might help in your endometrial carcinoma and possibly even your ovarian carcinoma. Do you screen these patients? The evidence there is quite conflicting as to what's the best thing to do. There are no randomized trials. And then you've got prophylactic surgery. And depending on the situation, someone will go for that, and they will go for this at a very young age. If they've completed their family, they'll come in looking for prophylactic surgery. And you kind of find, well, hang on, you're only in 20-something. Why are you coming for prophylactic? But you have to remember, they have seen this cancer in their family. They see it going across. There's a completely different attitude towards it. We've had Angelina Jolie, for example. There's a classic example of moving in and taking action on the understanding, of course, of the fact that her mother had died from ovarian cancer and her aunt died from breast cancer. So the view or the angles they take on it are very, very different to ours, and we have to appreciate that. So there are all those kind of approaches, but do any of them work? Probably the prophylactic surgery is the only one I could say does work. And if we do actually encounter people, by the way, in this scenario and they've hyperplasia, what do we do there? About 40% of women who have got endometrial atypical hyperplasia, depending on where you are, will have an endometrial carcinoma when you remove the womb. But we do try to manage some of these patients, and endometrial hyperplasia, particularly atypical type, will occur in premenopausal obese women. You can manage them for a period of time using the IUC, progestogenic IUCD, in a very constructed format as shown here from our college system. So I suppose to some extent we can reverse some of the hyperplasias from proceeding into malignancies, but again, not the easiest thing to do. And for the different types of endometrial cancer, as you can see, in both cases, oral contraceptive pill reduces the risk of both types of endometrial carcinoma. So that is a good preventative measure. We'll come back to that when we're talking ovary as well. What about other strategies? People have been looking at how do we manage, or is there anything we can do with obese women and have some form of preventative strategies as screening. And the evidence to date seems to suggest, as shown here, that the benefit of oral contraceptives as a preventative measure or screening, it doesn't really look like that's anyway cost effective. So for the time being, there's nothing being shown beneficial there. When you come to using the IUCD, which is progestogenic, it's potentially cost effective, but again, it will possibly prevent deaths from endometrial carcinomas in obese women. And these are the kind of things, this is the one that we would tend to use in certain cases of obese women with hyperplasia, whereby we cannot take the womb out. These ladies are too big. And it's quite interesting when you see ladies who are this big, whereby there might be 40-something, and they literally have difficulty walking across, or they're in a wheelchair, and the risks of surgery are just too high. This is what we'll try to do to see can we reverse any precancerous conditions and prevent the endometrial carcinoma happening. When we come to look at the oral contraceptives, I think there's a general consensus, of course, from all the meta-analysis that there is probably a beneficial effect in reducing endometrial carcinoma. This seems to be long-term, and it seems to be dose-dependent as well. And you can see here again, you see the never users, of course, have the greater risk of developing endometrial carcinoma compared to those, as I said, who've used it for various periods of time. So there seems to be a dose effect. And again, I say we'll come back to this when we come to ovarian cancer. So the reality of life is, at this moment in time, for many diseases, not just our cancers, obesity in endometrial cancer is probably one of the main factors. And therefore, if you want to get this reduction and prevention of these cancers, you've got to tackle the problem of obesity in the population. And I think most countries around Europe and elsewhere are trying to address how this can be done in a variety of ways. There are some ads going out in the UK from NHS trying to encourage people to not eat this, not eat that, take exercise, etc. But it is going to be a major, major challenge because of the prevalence of it at this stage in the country. Ovarian cancer is our most lethal of the gynecological cancers. So most of our patients die from that. So if we take all the gynecological cancers, deaths from ovarian cancer constitute the vast majority of the deaths. And the reason for that is it tends to present at advanced stage. So we will see patients where the disease is already spread, whereas of course you'd like to get the disease at early stage disease where you can afford more cure. And we've been struggling with this and trying methods to see can we actually prevent this disease happening altogether. Interestingly and not surprisingly, there is an association between obesity and ovarian carcinoma. That trend may not be to the same extent as we are actually seeing with endometrial carcinoma, but the association does exist. The IARC that said there was strong evidence of an association between obesity or adiposity and ovarian carcinoma. That's just, as you can see, coming out in recent years. The theory of ovarian cancer has been very, very simple. Fathala proposed the theory that the amount of ovulatory cycles a woman has in her life is directly proportional to her risk of ovarian cancer. And the idea was that with ovulation, there's certain damage that occurs, there's high mitotic growth every month, and the more that happens, it's more likely you'll get some abnormalities occurring and then go down the malignant transformation route. And we've had that for years, and it seems to be very good. There was always this concept of progression going from a benign ovarian cyst to a malignant ovarian tumor, which probably does occur for borderline type tumors, possibly. But we're trying to fit things in nicely to fit a pattern, if you like. It must go in this sequence. Problem sometimes with that is you get fixed in your mind that you think you've got all the answers, and you don't. Because most of the lethal ovarian carcinomas actually probably derive from the fallopian tubes. And we've now found over the last 10 years that most of it are agreeing that high-grade serous ovarian cancer isn't in fact ovarian cancer at all. And that explains why when we start to get patients where the disease is spread is because it's come from the fallopian tube, it's not from the ovary. And this has changed everything entirely for us and does cause problems in the prevention of this condition. We've found over the years, over the last decade, there are probably two types of ovarian cancer, the fallopian tube origin one and the real ovarian cancer. Granulosal cell tumours and such like are probably true ovarian cancers, but they're all relatively rare and can be managed mainly surgically speaking. So what about screening for this disease? Well, I suppose the concept is that if we are screening the ovary and it's come from the tube, we're screening metastatic disease. It's a bit like screening the lymph nodes in the axilla to find your breast cancer. And I'm sure you know what I'm going to say after this. Most of these screening concepts was to get the stage shift, was to get the stage 3 and 4 down to 1 and 2, where we can get better cure rates. It was never, we had no pre-invasive thing. We thought we did, but we didn't really. And the one trial that's come out from the US looking at this showed that it did not affect any mortality rate. In fact, the FDA has said no woman should be screened in the US. And this might be something some of you will come across when you're doing your clinics for various things and you've got younger people, whatever. You may come across women and they may mention to you about some screening for ovarian cancer. There is no screening for ovarian cancer. We've no evidence of benefit, unfortunately. The larger study, which was 200,000 women, this cost about 30 to 40 million pounds. The UK CTOX study, they published interim or predictive results, but they haven't really given us the primary endpoint. Does it affect mortality? So these are mathematical equations that they've undertaken. I'm not quite sure about all of this. I think you have to wait for the endpoint to come and to know whether it has an effect or not. I doubt it'll have any big effect, really, to justify the cost effectiveness of screening, because again, we're probably screening the wrong organ. We also, of course, as in endometrial cancer, have genetic issues with BRCA mutations. Now, these patients become quite challenging because from a gynecologic viewpoint, we will be looking and saying, maybe we'll take their ovaries and tubes out. And then if they're young enough, then they need HRT. And you're trying to figure out, well, if I give them HRT and breast cancer, what's going to happen there? That's what they actually worry about. In some cases where the BRCA mutation is so heavily leaning towards a breast cancer, the risks of giving them HRT are probably zero, because they've got 95% risk their lifetime they're going to get breast cancer anyway. But they are complex situations when you get into this area as to how to manage these patients. About 15% of the women with ovarian cancer are derived from patients with these BRCA mutations, and they're, again, mainly the serous ovarian cancer type. Again, as I say, we call it ovarian cancer, but a lot of these are probably from the fallopian tubes. The one piece of evidence that we do have in prevention of this carcinoma is, in fact, surgery. So it's not dissimilar to the endometrial carcinoma, but surgery in these type of patients, and these are the high-risk BRCA carriers, definitely get a beneficial effect from having prophylactic salpingo-oophorectomies. And that reduction is 85% plus. Some of them will get this thing they call peritoneal cancers, and that's possibly due to maybe somebody has a piece of the tube behind or other things that are occurring. We're still working on that. There may well be a true peritoneal primary carcinoma that occurs in women that does not occur in men. But these are for those who are carrying the genes. This does seem to be a very effective way of preventing their disease. And again, they will come to us. It's not that they're going to sit at home. They've seen it in their family. They will move forward, like the Angelina Jolie story, to come forward and say, I need to have this done to try and prevent the disease occurring. And everywhere we look for these specific patients, the evidence is very, very clear that this does work. The thing now that we're talking about, because we realize, in fact, we probably can't screen for ovarian cancer, that if we take the tubes out, because we know that's where the origin of the real killer of ovarian cancer is, should we go ahead and do that? So if somebody is having cholecystectomy laparoscopically, can we just turn it down and take the tubes out in these women? There's a great debate about this. The Canadians are really into it. They've moved and got prophylactic salpingectomies from surgery up from somewhere around 10% to over 35%. This is up in Vancouver way, because they see it as the only opportunity we can to tackle ovarian cancer. And there's great debates going on as what we should do. NIH get involved, not giving grants. because when you remove the ovaries, you may cause a premature menopause, which is quite interesting because when you look at the evidence, it's very, very shaky. But that's why one big grant did not go through, which is kind of an interesting thing. So this debate's going to go on for a wee bit until we sort something out. Hormonal prevention, of course, what can we do there? And interestingly, if you remember, I said the amount of ovulatory cycles you have is proportional to your ovarian cancer risk. That mathematical model still fits very well. So let's stop ovulation, use the oral contraceptive pill. The other, of course, is pregnancy. And therefore, we should see a reduction in ovarian cancer. And the reality is, actually, it is a very, very good way to prevent women developing ovarian cancer, to the extent that I would say if you want to use a contraceptive, why not use this? Because even if you use the oral contraceptive for a year in your life, you still get a protective effect 25, 30 years later, particularly when it's a condition. We won't be able to screen for anything at all like that at this moment in time. Our technologies aren't sophisticated enough to know how on earth we can find the precancerous changes in the fallopian tubes in an effective screening mechanism. So oral contraception is very good for ovarian cancer. Also, we find this, you get a significant reduction as well if you give this to women who are the BRCA1 or 2 carriers. So you can buy for a little bit of time to help them depending on the situation. But nevertheless, what you do find, as I say, is these women will come forward, complete their families if they're going to have a family, come forward and then ask for prophylactic surgery. So it's interesting when we talk about obesity, but for both of these malignancies, and particularly endometrial cancer, if you want to prevent a lot of it occurring at this moment in time, then tackling obesity is more than likely one of the more cost-effective ways of doing that. The oral contraceptive is a very practical way of preventing it, and remember, the effect of this goes for decades, so we're still measuring the effect of oral contraceptive protection, and it's been retained. For women who are in their 60s, postmenopausal, it's still going on. We haven't seen it fall off yet. For women who have got high risk of ovarian carcinoma, or indeed endometrial carcinoma, I suppose as well, prophylactic surgery is probably the best way for us to proceed. Opportunistic salpingectomy for those at high risk has been debated, but again, the big issue seems to be, and the prevention of research or trials in this seems to be related to the fact of the concern of causing a premature menopause, which I'm sure we could discuss that in detail. And I say for HNPCC, yes, you will get, I think, probably a benefit in those patients with the oral contraceptive pill, although the evidence is not truly available for that. But nevertheless, surgery is undoubtedly a way, once you take that womb out, we can guarantee you won't get endometrial carcinoma in that situation, albeit we'll hand over all the problems we caused to all of you to sort those out. Thank you very much for your attention.
Thank you very much.